Thanks, April. Today we'll be discussing the critique we performed on our nominated CPG. This guideline was commissioned by the National Institute for Health and Care Excellence and is titled Stroke Rehabilitation, Long-Term Rehabilitation After Stroke. As individuals, each person in our group critiqued the guideline using the Agree To tool and gave each item under each domain a quality score between 1 and 7. Domain 1 assesses whether the scope and purpose for writing the guideline and who it was written for is specifically described. Let's look at each item in a bit more detail. Item 1 was given an average score of 6. The target population was clearly identified as adults and young people 16 or older who have had a stroke with continuing impairment. The intent of the guideline and expected outcomes of implementation of the guideline were identified. For example, one expected outcome was a high impact on outcomes that the patient identifies as important. However, there was no discussion about what these important outcomes for patients are. Item 2 was given an average score of 7. We gave this item full marks as all health questions were displayed in a table with clear headings. Likewise, the question regarding dysphagia management was well written in a PICO format. Item 3 was given an average score of 6 because the guideline clearly identified the target population by age, clinical condition and severity, and also specified that the target population excludes children under 16 years of age or anyone who has had a transient ischemic attack. On the other hand, specific comorbidities of the target population were not described. Domain 2 assesses the information the CPG offers about the guideline development group, the target population and the target users. Item 4 received an average score of 5. Guideline development group members were identified clearly by name, discipline and institution. The group included relevant clinicians involved in stroke care, content experts, clinical administrators and methodology experts. However, policymakers and funders were not explicitly identified, the geographical location of the guideline development group members were inconsistently identified, and there was no description of members' roles. Item 5 received a quality score of 4. Whilst the views and preferences of the target population were sought with both patient and carer representatives in the development group, no literature review of patient values and preferences was conducted. In a supporting document called the Guidelines Manual, a patient and public involvement program is described. However, this information is not easily found. Item 6 received a quality score of 4. The target users of the guideline were briefly described as allied health therapists, nurses and psychologists, but were lacking other key members such as doctors and neurologists. Rather than a description of how this specific guideline might be used by its target audience, the guideline provides a list of how NICE guidelines in general can be utilised. Domain 3 assesses how the CPG was developed in terms of evidence and methodology. Item 7 was given a quality score of 7 because the electronic databases utilised were named, a full search strategy was included in the appendix and search terms were clearly listed. The search strategy was clearly defined in the guideline and the appendix as being in PICO format, with the health questions and PICO terms listed. Item 8 was given a quality score of 7. The criteria for selecting evidence was clearly described, the target population was specified, and the study designs included were identified as systematic reviews and randomised control trials. Exclusion criteria was also described and included studies that were not randomised control trials or systematic reviews, studies with less than 20 participants, and studies with less than 50% of participants with stroke. Item 9 received a quality score of 6. The study design and limitations of each study were clearly described. Magnitude of benefit versus magnitude of harm was identified, and the applicability to practice context was also considered in the guideline. For example, the guideline development group agreed that the high intensity of swallowing therapy in the evidence was not feasible in a practice context. The descriptions were appropriate, neutral, and unbiased. However, they were not all complete, and with direction of results and consistency across studies not described. Item 10 received full marks with a quality score of 7. The methods for formulating the recommendations were clearly described. The recommendation development process involved a formal process in the form of a modified Delphi technique, which was used appropriately where there was a lack of published evidence. Item 11 was given a quality score of 5. Whilst benefits and risks were not explicitly described, the trade-off between clinical benefits and harms can give us some indication of these. For example, the guideline described the risks of aspiration pneumonia, dehydration and death in untreated dysphagia and described improved quality of life for patients who returned to normal swallowing. Benefits and risks were considered in the recommendations. For example, the benefits and risks of thickened fluids were described. Item 12 was given a quality score of 5. The guideline links recommendations to an evidence summary that includes information about the method, outcome, quality of evidence, and limitations of the study. However, links between the recommendations and the evidence summary were unclear and needed to be interpreted by the reader. Item 13 received a quality score of 1. The guideline has been reviewed by stakeholders, but not externally. These stakeholders were involved in the process from the beginning when they discussed the recruitment of Guideline Development Group members, leaving them open to bias. Item 14 received a quality score of 5. The guideline specifies that it will be updated, citing the explicit criteria to be where the evidence base has progressed significantly to alter the recommendations and warrant an update. Upon reading the NICE Guideline Manual, it is clear that the guideline will undergo a surveillance review every 2 years. The methodology for updating this review is also described in detail as a 6-step process. However, this information was not easily found as it was spread between 2 documents. Now I'll hand over to Julie, who will discuss domains 4 to 6.